today's speakers, Smriti Rana from Pallium India, Vidya Shastri, who is a caregiver, Rohan Gupta from IIT Madras Alumni Association, and Prasanna Shirol from ORD India. And today's talk will be moderated by Mrinalini Ravi from the Ala Dumara Foundation and the Banyan. I'd like to welcome you on stage. Let's give them a round of applause.
Good afternoon, everybody. Thank you for being here. I'll just dive straight in. My name is Mrinalini, and I work at the Banyan and Ala Dumara Foundation. We work primarily with homeless people with mental health issues, one of the most marginalized and invisible populations in the world, as you can imagine. We actually have a very interesting panel today, except for one person who we hope will show up at some point. All of us on this panel are individuals with a lived experience of either a physical disability or a mental disability, or we have been caregivers for people with different types of disabilities and also engage formally in the caregiving space. I'll ask them to introduce themselves as they begin, so we save on time. Now, we all know this, that there are 1.3 billion people, around 16% of the world's population, that live with disabilities. But what some of us don't really talk about is that 80% of the 1.3 billion, 50 to 80% on a broad range, are people who have invisible disabilities. And my colleague already spoke about what these may be, but pretty much I'll just summarize it. Chronic pain conditions like fibromyalgia or arthritis, mental disorders, commonly, I'm just listing a few: depression, anxiety, bipolar disorders, schizophrenia, so on and so forth. Neurological disorders, epilepsy, multiple sclerosis, and so on. Learning disabilities, chronic fatigue syndrome, gastrointestinal disorders, PTSD, diabetes, some tumors, some traumatic brain injuries. So these are not often discussed. And I know the title of the panel is Invisibilization of Mental Disabilities, but what we have to understand is that invisibilization is very common amongst many of these disabilities, and mental health issues also share some of this invisibilization. So to ring everything together, it is important that we understand how invisibilization pans out across a wide range of disabilities. So, in fact, if you actually think about mental health, it has been visible. The disability and the experience of mental health issues has been visible across, through centuries, through millennia, since our conscious memory started. We know that there have been people with mental health issues, and there's also been pushback from people with lived experience of mental illness, whether it's the Bhakti movement or the mad saints across the world. That mental illness as an experience has been shared quite widely, and there's also been pushback against the oppressive forces that exist in society and across systems. The Mad Pride movement, Mad Studies movement. So there has been some visibilization for mental illness, but amongst the invisible disabilities, the societal norms that are not fulfilled are often, for people with invisible disabilities who cannot talk about their experiences, including menopause, for instance. It causes so much more duress because you're not able to express yourself. There is no language to articulate what you're going through. There are no support networks. There are no support groups that, especially in our country, that talk about some of these things. So you're constantly pushing yourself, pushing your family, pushing each other to, meet these bizarre expectations, and that leads to a high level of stress and duress. So what I would request the audience to do is to think about invisible disabilities and unpacking what they mean, and also unpacking invisibilization of disabilities. If our speakers have already covered, your experience, then great. But if you'd like to then say something or share something, I will request you to hold all your questions and your experiences till the end, so we give them a fair chance to complete what they have to say. And then we'll dive into the Q&A. So they'll speak for about 8 minutes each, and then we have about 25 to 30 minutes of Q&A. So thank you very much again for being here, and I look forward to this very enriching session. Thank you. So I think we'll dive straight in with Vidya. to speak about yourself and your lived experience. Thank you.
Thanks, Mrinalini. Um, Thanks, everyone, for coming in. I would also like to thank, of course, the organizers for calling me and to share my experience and challenges as a caregiver. This is the first time I'm sharing this on a public space, so I'm a little shaken by the process myself, but I hope I'll take you through. That's why I've written down what I have planned to say today. And so I hope you don't mind. I'll be reading out most of it. So, yeah, to start straight away. Well, I have been in the NGO sector for the past 3 decades or more. Largely worked in the craft sector in rural areas and later also in the area of disability. Actually, simultaneously have been working in both the sectors, largely in the rural areas. So with NGOs, the last job I held was with ADD India. And right now I'm free. I'm trying to retire, but I don't know. Well, so to straight away start how I come into this space is I've been a primary caregiver for my daughter, apart from being a mother, from the year 2006, when we met with a road accident. She was 6 years old then, and she had a head injury. It was called diffuse axonal injury, a traumatic brain injury, for which the immediate treatment was induced coma. She was put on a ventilator and discharged from hospital a month later with her vital organs were functioning. At first, we knew only of the visible physical disabilities. She had to relearn stabilizing her neck, sitting, standing, walking, running. She was 6-year-old by then, so she had to relearn all this. And there were also complications in her sight and speech, but she overcame all this with a rigorous mix of physiotherapy, yoga, Ayurveda, and most importantly, her own willpower. We also included fun things like dance and skating to lighten the burden of treatment and therapy all the time. Today she's 24 years old and she's been working for the past 1 year, which is a very... She still has a few minor visible disabilities with regard to her sight, her gait, her tremors in her hand, but none of these really bother us too much. It is really the invisible disabilities that are a challenge. Like Mrinali said, these we are not able to express it, but we learn as we go along. So she falls into the category of learning disability, and this categorization is fine for the institutions, for getting admissions in college, school, for getting a job, all that. That's fine. But the challenge really is in daily living. So what I would like to give examples about is a couple of examples how we overcome some of these things. There's still we are not able to find solutions for. So the first thing I would like to describe in a bit of detail is about something as simple as reading. Initially, I thought she was not reading because she had a difficulty in her eye muscles for movement while reading one sentence and coming back to the next sentence. So that was the difficulty. But soon I realized that she didn't seem interested in reading at all. And also because of not reading, her general knowledge was poor. And the real outcome of it in society was she was not able to keep friends, not be part of groups of friends especially, because she wouldn't be able to participate in any discussion. So then I started coaxing her to read headlines. I would say at least 5 headlines is good enough every day. And she tried, but she would give up soon. And then I kept coaxing. I didn't know any other way. Then I was observing carefully and I found that she was struggling with reading because she was not able to understand what she was reading. And of course, now I realize it's the same way I try to read Kannada or Tamil. I read the whole sentence, but I sometimes don't understand what I have read. So I broke that down, the headline especially. I said, okay, she needs to understand the context. She needs to have some general knowledge about it. So I just thought of an example, like the other day, on Thursday specifically, about the rains. In Deccan Herald, there was a headline saying, North and East done, rain now to CBD and South. Now this is cryptic. It's also got CBD, an abbreviation. So, but she read it, and fine, that was fine. The first level was done. The second level about abbreviation also she found on Google. That was fine. And then she has also seen that it's been raining, so she knows the context to some extent. But why are they talking about, and that the reports so far have been about the north. We live in Yelahanka, it is the North Bangalore, but to know that that is the context and now it's moving to the south, she had not realized. Also, her knowledge about urbanization of Bangalore or the green Bangalore is limited. She knew that, but she didn't connect it. So connecting, just reading, understanding the context, knowing some general information or general knowledge about the topic, and then connecting all these together takes some time. So an headline like this would take me to 10 minutes to 15 minutes to sit with her and understand a headline, something about rain that she's seeing every day and still. So how do I make her read 5 headlines, which means 1 hour every day? She doesn't have the time, neither do I, and we end up not going ahead. So this is about simple headlines. So reading a story would be something more. We have still not figured out how to keep that going. We are just going with building the habit of reading, like we do for all of us do also. So in these cases also, sometimes social media helps. She's on Instagram, so some information she gets there. Google is there, and so she does find out some things on her own, but there is also a lot of wrong information sometimes, so that creates even other complications. Another example I would like to, so the invisibilization here, the connection, understanding that her reading is affecting her friends, her ability to make friends is a connection I made after maybe, I don't know how many years. And this headlines understanding happened only when she was around 18. So by then she was already 14 years into, she could read, but she was not reading. So there are other things also, seeing, understanding, and responding, 3 different parts of it. For example, we would tell her, why don't you go to the grocery store and come back? So we'd give her directions, walkable. She would go, and then we would give her directions, the name of the shop, how the name board of the shop would look, all landmarks around and things like that. She would go, but still call back and say, I'm not found. And then I would go to find where she is, and she would be standing right in front of the shop, but still not, because it has not, in her mind, the visualization of the grocery shop was something else. And she didn't see that in front of her, so the registration didn't happen that this is the place I was. So she's followed instructions well, but identifying that. So this is another kind of, and we can't be everywhere, so she has to overcome these slowly. And I don't know how one trains a person in these things. The most recent challenge that I have discovered, which again we are struggling with right now, is emotion. Understanding, I think it is there for all of us, understanding an emotion, why we are feeling this way, or what triggered it off, or what. And the difficulty for her is then that becomes an opinion of the character of the person rather than whatever action has made her angry or happy or whatever. So that's where we are today, struggling with some things, not finding solutions somewhere, sometime, suddenly. And yeah, it's just because it's invisible. She looks fine, she's fine. People don't understand why she's not able to do certain things. And we ourselves, particularly, I am always making mistakes and not realizing much, or realizing much later what it really meant for her. So that's all I would like to share. Thank you.
Thank you so much, Vidya, for sharing experience. I know it wouldn't have been easy, especially you doing this for the first time. I appreciate it. We all appreciate it. Rohan, please introduce yourself and would like to share your experiences, please.
Hi, good afternoon. My name is Rohan. I know it says in your program that I'm working with IIT Madras Alumni Association. I want to make it absolutely clear that I'm not here to represent the institution. I'm here in my own personal capacity to share some of my own lived experience, as well as the fact that I volunteer with an organization called the Ekalavya Foundation for Mental Health, based out of Pune. and a global company called Cities Rise, also a nonprofit based out of New York, but we operate in 4 continents. Um, so when Mrinalini approached me about this, I was first a little surprised because this is, again, the first time I'm doing something like this. But I took umbrage with the word disability because what I'm here to talk about is perhaps more disadvantage as opposed to disability. And a lot of that has to do with the way society, especially in India, is constructed. What we expect from one another, what we sort of have built for ourselves. So I'm here to speak on a couple of things that I have experienced in my life. First of all, I'll put this out there. I suffer from adult ADHD, which was diagnosed maybe 3 or 4 years ago. It was something I had no idea even existed. And to this day, it's very new. Most people don't know what it's like. I was always told I was lazy, I was procrastinating, I couldn't start tasks, I couldn't finish tasks, and I started to believe that myself. And only later on in life, when I met a wonderful therapist, did I realize after filling out a questionnaire that I had something called adult ADHD. And so, what are the solutions for that? Yes, there's medication. Um, Somewhat helpful. But you have to go through a day to day relearning, as you said, where I have to start my day and literally make a list. Brush your teeth, have a shower, go to work, eat your food, drink water. So that's one part of it. The more important part that I want to talk about, which is an invisibilization, because this is something that I live with. Again, I'll come to the end of it. I'll sort of tie it all up. But the most important thing I want to talk about is being a queer person in this country. I grew up in a country where I was told it was illegal to be who I was. Until recently, it was 377, I'm sure you all know about. It went back and forth in the courts. So, as a result of that, I honestly did not know how to express my own identity. And I'm not going to speak about the trans experience because I don't have enough experience there, but I mentor a lot of young gay people or queer people here in India as well as abroad. So I can speak a little bit about that. I can't see the time, so if you can just, yeah. So very quickly, what does it mean being queer in India? So I started a job recently, not at IIT Madras, somewhere else. And one of the first things I was asked was, "Are you married?" And technically, I am married. I'm married to a man. We're separated. He lives in America. I live in India. Now, that's a lot of qualifiers there, right? How do you answer that question? Second story, I had to have a very minor surgical procedure done, and I went to Apollo Hospitals in Chennai, best hospital in the country apparently. And I had to meet the head of general anesthesia because I was going through anesthesia. And she said, "What conditions do you suffer?" So I said, "Okay, I have ADHD, I have anxiety, depression, this, that. What medications do you take? This medication, that medication. What about family history? Parents also have depression, anxiety. Why don't you marry a good Tamil girl? Everything will be fine." You're a doctor and you're the head of anesthesia at this prestigious hospital, and this is what you have to tell me. So, how does one answer these questions? But this is society putting us at a disadvantage because we are not supposed to ask these questions, we're not supposed to answer these questions. It is unfair. And I know fair is a very strange concept nowadays, but it's not right. The last thing I want to talk about is, again, about being queer. So, like I said, growing up, it was illegal to be gay. I moved to America. The internet came about. We all have smartphones. There's an app, dating apps. Everybody probably has. Some of you, maybe. I don't know. But for the queer community, it meeting people was always a problem. I grew up as the only gay person I knew in this country till I moved out. Um, Maybe there was one more person. But meeting people also has risks associated with it, right? Gay people meet at bars or clubs or bathhouses. I know that's something that maybe a lot of you don't know about. And it's inherently high risk behavior. Even today, the apps that we have, we're meeting strangers. We're letting them into our houses. I unfortunately have had to deal with a lot of people that I mentor who are young. I'm talking about 18 to 25. I'm 38, 18 to 25, who have faced sexual assault because they have gone and met somebody and the expectations and consent and the rules associated with that engagement were not very clear to begin with. And that brings me to my last point, which is substance abuse. Like I mentioned, gay people used to meet at bars or clubs. Inherently, the expectation is that you are going to be drinking or today doing all sorts of drugs, GHB, LSD, all of them. And it is a problem. So the last story that I want to tell is about somebody that I know personally. Now, I know we're supposed to be in an Indian context, but this is somebody who lives in London. He's a bright person. He's my age. He went to a very leading university, studied fashion, worked in Soho in a boutique with a very famous fashion designer, who, again, I will not name. And within the span of 5 years, he started using drugs, contracted HIV, contracted hepatitis C because needle use, was homeless, today lives on a metro platform and begs for money just so he can get his next fix. Why does he do that? I've asked him. He's been to AA, he's been to NA, he's been to rehab, he's been to all of the programs. NIMHANS has a wonderful substance abuse program here. He doesn't want to give it up because life for him is hopeless. And that is what is tragic. Here is somebody who's in the prime of their youth, could be contributing and could be a productive member of society. So this is how we as a society have invisibilized all of this. Now, substance abuse is a very visible part of it. It's what happens at the end. So someone with ADHD, I struggle with impulse control. Very easy for me to, I smoke cigarettes. Very easy. I've tried quitting many times. Disadvantage versus invisibility. I don't like the word disability because I'm not speaking about that. Other people have spoken about actual disabilities, and I can only relate and understand what you're talking about, chronic pain, or in your case. I think my time is up. But lastly, I'll just like to say that try and recognize this. How do we talk to each other without judgment, right? That's what we're here to do. So, thank you.
Thank you. Thank you very much, Rohan, for sharing and for your candor. I think just before we get to Smriti, and since we have a little time on our hands to talk, so I think here we need to pause and just think about reasonable accommodation. It's still very much in its nascency. I don't know if we've started taking it as seriously as a science here and who are all involved in the conversation. But, you know, when we're talking about impulse control for someone with ADHD or, you know, in cases of mania for people with bipolar disorder and excessive spending. So where do we, you know, where are the disadvantages and sometimes disabilities that they experience, and what do we as a system, as caregivers, as maybe others with lived experience, how do we navigate some of these things that they really are invisible, and, you know, we need to bring it into our conscious mind. So just to pause for everybody to think about reasonable accommodation, and then now on to Smriti. Smriti, thank you for joining us, and request you to start.
Thank you. Thanks for having me. I'm Smriti. I work with Pallium India. We're a 21-year-old organization in the field of palliative care. And just to sort of set the record straight, we don't work on the Western model of palliative care, which is end of life and hospice only, but across the spectrum. And the way we view it is that it's a social intervention rather than just a medical intervention. I've been a caregiver to several people, including people with cancer, interstitial lung disease, and addiction. And I've been associated with palliative care now for 23 years. So I know that the memo said chronic pain, but I'm just going to make that one part of what I really share. So I'm going to really touch upon 3 different aspects, the first being pain. So the previous session in this auditorium was about suicide. And just to use that framework, in 2014, it was reported in the National Crime Records Bureau that upwards of 26,000 people had ended their lives because they were living with a painful or chronic or advanced disease or a condition. That's a huge number. It was like 1 in 5 of the suicides reported that year. 2021 saw a huge jump. Just between 2020 and 2021, there's a jump of 7.2% in suicides. Again, second leading cause was living with suffering. So now the Lancet Commission in 2017, we call it serious health-related suffering. But if you expand it, it means one person being sick. What is all the health-related suffering associated with it? There's catastrophic out-of-pocket expenditure. 55 million Indians are pushed below the poverty line because of healthcare cost. So the system that is meant to treat you is causing more suffering. And so pain, just as one component of suffering, did you know that till 2019, it was a non-examinable subject in the medical undergraduate curriculum? There were no points for treating pain. So generations of doctors don't know how to do it. That is compounded by the fact that we have this really draconian Narcotic Drugs and Psychotropic Substances Act. It took us 19 years to change that act so that you can get pain relief today, and you still don't get it. Now, if you're living with that kind of pain, you also have to remember that pain is it's very subjective. What I ask you on a pain scale, 1 to 10, 10 being the highest, all factors being the same, you'll all report different numbers. It also depends on your life circumstances. Someone who's relaxed today with a headache is very different from someone who has a debt to pay off, has a loan to pay off, who has a sick child, who has deadlines they're not meeting. That's number 4 for one is going to be a number 8 for somebody else. So I need to have the skill to see what your pain really means to you in a social context. And how many people have that skill? So only in 2019, the undergraduate medical curriculums, they introduced something called 8COM, attitude, ethics, communication, and elements of pain relief and palliative care. That's great. Who's going to teach it? Because your doctors have not been taught it. So we are now creating the modules, by the way, to train doctors in government hospitals to teach it to the next generation. So I wouldn't be too optimistic about pain relief for the next 5 years at least. Sorry, Rohan. And speaking of substance use, there's something called the principle of balance, that you stop misuse and diversion. But a lot of these substances that are controlled are also used for medicine and science. But your laws, thanks to the war on drugs, is leaning heavily on control and regulation, not on access. So that's another fight we're fighting. So all of these factors basically go towards making pain. We don't want to know about your pain because we don't have the means to treat it. Actually, we do, but we haven't learned it. The second thing I wanted to talk about, just segueing from pain, is the burden on caregivers. And I'm very pleased that Vidya is on this panel today because caregivers historically have been invisible. We call them in palliative care invisible patients. And there's one thing I want to request of everybody here. Can we please eradicate this word bystander from... No, seriously, because a bystander is someone who stands by. You cannot call the primary caregiver of somebody a bystander because you're the last... You are in that ring with the person, fighting everything. So can we please eradicate that? I want to start a petition, please. And also, the other thing is that 80% of caregivers are women, globally. The most disempowered person in the family will usually become the primary caregiver, providing the direct care, the bed sore management, the toileting, all of that. The finances somebody else is handling. So she's not the decision maker, but she is the one who's doing it. So again, the invisibilization also happens because of gender. And I think it's a very important intersection, this caregiving and women coming together. Also, she's the last to then prioritize her own health, and then that goes into another cycle of no health-seeking behavior and so on and so forth. So that is something that we really need to pay attention to. And there's a saying that we use in advocacy. If you don't have a seat at the table, you're probably on the menu. So women are largely on the menu everywhere. So that's another thing that I would strongly advocate for. The last thing I really touch upon is, again, following some sort of logical sequence, grief. And grief is not just after someone dies. You have anticipatory grief even as you live with suffering. And I really want to reframe this. Grief is not a disability. It is the most, it's what accompanies, if you're human, you are going to feel it, okay? But it is disabling because society doesn't know where to locate it or situate it. Now, there's this wonderful book called On the Wild Edge of Sorrow. It's by Francis Weller. He's a psychologist. So he speaks of attunement. Attunement basically means a very particular kind of attention that you pay with kindness to hold space for somebody as they're grieving. But now with more nuclear families, with with fragmentation of society, community, whatever, we don't attune people to their grief anymore. So grief suppressed becomes symptom. So a lot of what you're seeing is just symptoms emerging from not holding space for grief. So I'd really, also encourage us to hold those spaces better because it is not a disability. It is disabled by no attunement by the rest of us. So the last thing I'll say is that this is again something that I'm borrowing from Francis Weller. We have very successfully imported one thing from the West, and that is how to deal with everything through amnesia and anesthesia. You will try and forget about it or numb it. And as a result of that, grief and other pathologies, in quote, have just been colonized by the clinical services. You try to numb it or make someone forget about it, right? We need to stop doing that. So I'll stop with this for now. Mrinali.
Thank you so much. That was very succinct and very useful. Before we move to the audience, and we do have some time on our hands because one of our speakers, I think, sadly couldn't show up. I think everybody here may be aware of the social model of disability that was developed by Irving Zola, I think in the 50s or the 60s, about placing the impetus on a society, a family, or a community to ensure that equality becomes real for all of us, right? Irrespective of where we're born, how we look, what color we are, what impairments that we may have. The disability is actually the society's and not ours or the persons who are experiencing it. So from that standpoint, I just want to throw questions at the speakers, and whoever wishes to answer can do so. Where do you think, in your lived experience, this whole not being able to meet expectations that society sets for you, these are all very bizarre, I said it in the beginning itself, but these are things that we have as a community decided that we need to do. Go to school, go to college, get married, everything, right? So where in your lived experience, have you faced issues with this whole notion of expectations and not being able to meet them?
I'll take one part of it. Caregiving is the expectation on the caregiver is, oh, it's a sense of service and duty and all of that. It may be partly that, but I think we need to be able to support caregivers better, because it's the expectation is that you will drop everything in life to do this, and then you are deprioritizing your own struggles, because hey, this person is dying of cancer. Who are you to cry about not getting your promotion at work because you haven't shown up at work? So I'm glad that the conversations around caregiving are more visible now, but I'd really also like to see more caregivers in the decision-making spaces, because even if you go in healthcare, I think if you go from ground up towards management, you have the most number of women deployed on the ground. But as you go higher and higher into management and senior positions and policy spaces, you don't see. I don't know what the Indian numbers are, but it's less than 30%. So that's something that I think needs to be done.
And thank you. So we will keep that in mind when we come to the next question on reasonable accommodation. So anybody else would like to answer this question on expectations?
I think there's expectations that society places on one, but they're equally the same number of expectations we place on ourselves, based on what we have been conditioned to sort of believe is the correct way of living, right? So get married, have children, go to school, graduate. So failure is something that we don't talk about in our society, especially in an Indian context. How do we prepare ourselves for failure? I think that's very important, because we all have failed at something or the other, right? We wouldn't be human otherwise. And so when it happens for the first time, your entire world is collapsed. And how do I deal with it? And it's happened to me many times. But now I'm used to it and I can deal with it. But we need to teach our kids that it's okay to fail. And it's okay that academics are not everything. That's one other part of it, because we put so much pressure on our children today. So yeah, failure.
Thank you. Vidya?
I would like to mention the expectation expectation that we all have, that this would be sorted if we have a right law. The Disability Act, Rights of Persons with Disability Act, has rightly put the thing on the the disability, saying that the environment is disabling. That's fine. But for instance, the percentage of disability is a thing that has to go through. So it leads to a whole lot of corruption and a whole lot of other things. And then, like I said, the experience of mine has been that yes, she could get admission into college and into school, or she even got a job perhaps because of that. But in daily living, there is still expectations. She goes out, she goes into an auto rickshaw, or she goes into the bus, she wants to get off at the next stop, she gets up from her seat and is walking down, but in the rush, in the pull and push, on the way, the conductor wants to know, do you want to get off here or not? Or because he has to tell the driver to go on or wait. So she either gets off earlier, or she gets off later, or something happens. And well, people scold her, or which she ignores. Luckily, thankfully, she's learned to ignore. Or she has to find her way home because she's got off at the wrong place, which is another set of things. So the expectation to respond immediately, and then the expectation that law will solve it. These are two things that law cannot solve. We have to, I don't know how it's going to happen, but all of us need to have, I guess, some kind of divine patience, I say. I've also struggled with that. So, yeah.
I think this is very realistic, because we, to live it every day and to both live with a disability and then to care for somebody with a disability, mental health, physical health, whatsoever, there immense patience is required at both ends. So we're still navigating that, and there's no solution. But yeah, thank you, Vidya. So before we get to reasonable accommodation, that'll be more of a conclusion. Do we have questions from the audience? No one whatsoever? Okay. All right, that's fine.
You're all invisible.
Yeah. Can we talk a little bit then about reasonable accommodation? And I think we will, in the history of panels, end fast. I don't think it's ever happened in the history of any panel, but we will end fast. So if we can just delve a little bit, and since we have the luxury of time, about reasonable accommodation and what your expectations are, yours and yours. When we talk about reasonable accommodation, we say, we at the Banyan, like I said, we work with homeless people with mental health issues and very severe mental disorders, as a result of which they are forced into the streets, right? So this is years of, it's first of all a large number of people. If you see, 80% of people with disabilities live in Islamic countries. 20% of the world's poorest are those with disabilities. So we're looking at someone who is born into disadvantage, socioeconomically and politically, higher propensity of mental health issues. I'm only talking about mental health now. How higher propensity to develop mental health conditions. Then you develop it. 2 out of 10 people typically in the country have access to appropriate and affordable care. So there you're again at a disadvantage. Then you are burdened by a biomedical system that, like she said, it's been colonized by doctors. Caregiving has been colonized by doctors. So not too much resources, not too many resources that are being invested into sort of holistic rehabilitation or intervention. And then you're thrown back into the real world, where we say that, recovery, now they're doing very well, they have a job. It's almost as if people who don't do well cannot have jobs. So what we have, our women, we advocate for in NREGS for them to, you know about the NREGS, right? The 100-day employment guarantee scheme. So in that we say 8 hours you're supposed to work and you get $100 a day. We advocated for 5 hours and 120. And we saw that it brought more people into the workforce, more, so the mother and the child, or I'm not saying child as in under 18, mother and somebody with a mental illness could come and they can be together, and then they can work together, they get paid for it. And the money goes straight into their account. So that is one example of reasonable accommodation. So Smriti, does that answer your question? Yeah? So if you'd like to get into it.
Okay, I hope I've understood this right. So I was having a conversation earlier today with somebody, just to sort of echo what you said. I have this wonderful friend, Dr. Roop Gursahani. Some of you know him. He's a neurologist. He once said, modern day hospitals are like fortresses. The poor can't get in and the rich can't get out. And yeah, and the other thing, I did say we imported amnesia and anesthesia, but we also imported a whole lot of neo-colonial ways of thinking, right? So just to give you an example, right now there's a conversation going on worldwide about a good death. And the problem is, a good death is in the hospital, well medicated, no pain, etc., family around you. Great, it sounds great, but that's not the reality for most of us. Does that mean we're dying badly? Yeah, on many parameters we are. But we need to stop comparing ourselves to that template. The evidence we're following right now is a very Western template. The evidence is coming from there. Like 95 in palliative care, 95% of the evidence comes from 15% of the world, which is all high-income countries. It doesn't apply to us. So the solution to that in our work is to involve the community in the delivery of care. And for me, I suppose the reasonable accommodation part comes with participation of the community, to the extent where you don't have to be we're not asking you to be clinicians, but we're asking you to be our eyes and ears on the ground and point us in the direction of someone who might need that kind of care. So earlier I said that palliative care for us is a social intervention, not a medical one only, although there's a lot of medicine in it. There is less than 4% of Indians have access to palliative care. So there's one palliative care physician for 1 million Indians, just by the way. So you have to involve the community. You have to involve them in the design and the implementation and give them the ownership. So I don't know if if I'm coherent with what your question was, Mrinalini, but that's one of the ways in which we see this. And also the other aspect is that one of the first collateral damage in terms of financial toxicity is the child's education. So much money is going towards cancer treatment that the child has to be pulled out of school so that that money can go towards treatment as well. So the illness of one person in one generation has multi-generational impact, and this cycle continues. So part of what we do is educational support for children. Is that palliative care by the textbook sense? No, but it is palliative care in what we do. So we've supported about 300 plus students, of which now I'm very pleased to tell you many have decided to become doctors and nurses. You have to also provide food. You can't give free medication if the family is starving. So those are some of the ways in which we've been doing it for the last 20 years, and yeah.
Yeah, thank you, Smriti. This is precisely what I'm talking about. So just top-up services, which actually may end up being the lifesaver in so many ways. So, Vidya? Yeah.
Yeah, reasonable accommodation, again coming back to the law, it's provided by the law for disabled and even in the Mental Health Act. But how much of it actually happens, I don't know. I was offered, of course, to work, but it is work, and it's an NGO. That's different. It doesn't happen I don't know about the corporate sector. I don't know how much of it happens. Reasonable accommodation does happen in institutions of higher education. And there are several NGOs working on it. I mean, I worked with an NGO in the sector, and there is BNI, who are sitting here, who are working in the rural areas, and like you said, getting the community to take charge. But reasonable accommodation, what we really need to make, I mean, the law is there. One is creating awareness about the law and then ensuring that it actually gets corruption or not corrupt. That's another matter. But for us as people, as a society, to even understand this, to understand that there is a person in my family who needs to attend a wedding or a social function, and it's okay if she or he has to come in a particular way, prefers to come in a particular. How do we understand that? How do we provide for that? What accommodation would we provide for the family to actually come and be part of whatever else is happening there and not stay out? I think provide for them. And so again, the society and community, a family, a village has to provide for them. And that needs to happen, yeah, I think.
Thank you. Thank you so much, Vidya. Rohan.
Forgive me, but I'm just going to take cognizance of 2 points that they made. One, the law, right? We can't wait for laws. I've had a Supreme Court and a High Court tell me whether I was legal, whether I can get married, whether I can adopt children, all sorts of things, right? We, as a society, cannot afford to do that. And the second thing that really struck out to me was financial distress as a source of pain and debt as a source of pain. We don't think about that enough. So sorry, Mrinalini, I know I'm not answering your question. But when it comes to reasonable accommodation, there are 2 words that come to mind: empathy and dignity. We need to be, as a society, more empathetic. We need to respect the dignity of every person as if they are us. Whether they work for us, whether they are a driver, whether they're an auto driver, or taxi driver, I don't care. They are a human being. And I'm sorry, but like one of the things that has always come up with me when after I moved back to India last year was everyone said, "Oh, you lived in America, you have to do everything yourself. You even clean the toilet." I mean, what is the big deal? It's your toilet. You are the one that is using it. You are the one that's creating the mess there. You might as well clean it yourself. But so that dignity is something that is really important, and we need to instill that, like you said, from a very young age, because it's not right that we treat each other. We are a hierarchical society at the end of the day, right? I'm not even getting into caste or gender politics, but we love our hierarchy. People call me sir when I'm in. I'm like, you're older than me. How can you call me sir? So that is something that needs to change. That dignity has to be accorded to each and every individual, irrespective of gender, sexuality, disability, whatever, profession. And we have to be empathetic. We have to try and put ourselves into other people's shoes. And I'm not saying you have to agree with them. You just try and understand what their life experience is like.
Thank you. Yeah.
Sorry, Rohan, you were talking about being legal and getting married. Also, dying is going to be difficult for you. Yeah. Because it's not, for advanced medical directives. Now, the latest version, we've actually put in a section that non-blood family can be your healthcare power of attorney. So for those of you, I mean, I don't know if you know about advanced care planning and advanced medical directives. It's really important because that's one of the ways in which you can take charge of at least some aspect of your, the end days. Yeah, so a living will, yes. But now, yeah, so advanced medical directive and living will is the same. And the template has been now, we've worked with the Vidhi Center for Legal Policy. So it's a much more comprehensive document, which also takes into account location, who you want to be treated by, and who you want to make decisions for you. So that's one little bit we've tried to sort out. But that's one of the things I think we need to get more involved in. Sometimes we think that it's too early, but it's too early until it's too late. So these are things that we do have to pay attention to, and I just wanted to put that on the table.
Thank you, Smriti. So, just so you know, I read about this very recently, that electric toothbrushes and audiobooks were developed for people with disabilities, and now we are all together taking advantage of it. So yeah, so we're not talking about a population from Mars over here, right? We know it's all of us in this room, so many of us in this room, whether we do or do not like to talk about it. So reasonable accommodation has impacted so many of us, and it was created for a particular population. Since we don't have questions from the audience, I will throw a question. Oh, you do have a question. Okay.
Thank you. From morning I have been into various sessions, and a lot of it what we are talking, I'm in the space of community mental health, and we work with different NGOs in the rural areas with seriously mentally ill people. And so much of it I'm trying to connect. How do I, connect what we are listening here, learning here to the community? It's really, I don't think it's really easy, because what we are now talking about caring, about reasonable accommodation, when they don't even know it's a illness, they don't even know I'm a carer, then what do we talk about reasonable accommodation? There is no identification that they have a difficulty, or there is a disability, or whatever. It might be different things. So I'm really concerned about that. Then how do we take in that? I just wanted to share it, because we need to keep that also at this level where we are talking, and that is what the major. And we know, treatment gap around 80%. So they don't even know they have an illness, and nobody is identified as a carer. In the rural, they struggle for their life, and they have to care, and nobody is even recognizes them. Then how do we, take it there? What do we do? I just want everybody to keep that and see what can be done. Thank you.
Such a valid point, and before the gentleman asks the question, just want to say that when we talk about these are all terms. There's reasonable accommodation, there's justice, then so many things. It all weaves into one another. I don't know how many of us here have knowledge of epistemic and hermeneutic justice, or it's just a bunch of fluff. I'm not sure, but what we're talking, hermeneutic justice refers to a concept where you make sense of your own experience, and that is something that is so ignored because history is written by the victors, or so called. Textbooks are written by people who live miles away from us, and we've never met them, and they've never met us. So your diagnosis is being given to you, written by somebody else, and explained by somebody else who understands it differently. So it's all Chinese whispers, right? So when you say, madam, that you're talking about awareness, and nobody knows, we keep putting up posters about mental health. All the DMHP centers, Banyan, many organizations, we keep putting up posters. But what does the poster say? Symptoms of schizophrenia is XYZ. Symptoms of depression is XYZ. Where does it start? What is the daily lived experience, or how can I make it more relatable? How can I make you understand, or how can I make myself understand your experience, and how can I be humble about it, that not come from a place of presumption, but coming from a place of humility, and coming from a place of sort of saying that I don't know. Like, even when we talk, there's a video which maybe we could have shared here. It's called Awkward No More. I'd request everyone to check out that video. Sometimes when you go near a blind person and shout, they're not deaf, but you go and shout into their faces, or you go to someone in a wheelchair and go really close to their faces and say, nice to meet you. No, I can hear you, I can see you very clearly, just don't get in my face, right? So how do we, but the thing is, it's okay to say that, hey, you know what, I didn't know, I'm really sorry. There's no point in us getting cancelled for something like this, but just to, from both ends, to come from a place of humility and say, I don't really know, and I don't know what to make of my experience. And I think until we get to that conversation, how many ever pamphlets we make, how many ever videos we make, it may not make sense. So I think that's why for us it was very important that people with everyday experience of disadvantage or disability are part of this panel, or people who represent them are part of this panel. So we make more sense of what is it that we're dealing with. So thank you.
One of the things, I know the work you're doing. So one of the things we could perhaps do, I don't know whether it is actually possible on the field, is while after speaking here today, I'm realizing, identify one person of the community whom you've already been in touch with, to come and share, who knows that they are caregiving, especially the mothers, right? So, and you have parents groups of caregiver groups, so get them to speak in the larger group maybe. I don't know how you could turn that. Yeah, but you're right, we need to get this across there.
So, ma'am, I have a question that how we see this problem as a multi-dimensional plus the deprivation factors, and in some areas of India, like flood-prone areas, so they have a yearly this kind of trauma comes into play. So, how government sees it and how the development sector as a whole see it, if somebody can answer.
Would anybody, you want to take it on?
So if you talk about the mental health things, for example, so if you say the flood-prone regions, so it is a yearly thing for them. So there is no, you cannot measure it. So it's a sense of social inequality, deprivation, and everything. And even the government do not consider it. And how the social sector can take into account all these things. So
I don't think I'm the right person to answer this question, but last week in Chennai we had a flood, and you had one recently in Bangalore as well, right? Yeah, that's a trauma that people experience. I lived for a brief time in Puerto Rico, where they have a hurricane season, and I was there for a major hurricane. We lost power, electricity, there was no water because they don't have tanks in their buildings. It's a trauma that needs to be addressed. I don't think we are equipped, especially in this country, to really deal with it, because it keeps happening and we aren't fixing it. So Write to your MP, write to your chief minister, write to everybody that you can, because that's the only thing that you can do.
One of the things that we did in Kerala is, this is exactly where cross-sector partnerships need to come. So we worked with the Disaster Management Authority of Kerala, because after the 2018 floods, we realized, so why did we get into the picture? Because after the initial rescue and repair and all that comes rehabilitation, and the people who are most disenfranchised were people who are already sick. Your triaging logic is that you have to allocate resources to the ones with the highest chance of survival, which automatically puts people in wheelchairs, bed-bound patients at the bottom of the food chain. So we had to step up for our, the cohort we were looking after and saying, no, you cannot deprioritize them just because they're bed-bound. So for us, the rehabilitation part, our work is actually the longest even after the Wayanad floods, for example. So for us, that was a clarion call to really start talking to the Disaster Management Authority in the country, in different states. So we have partners in Assam who are doing that with the Assamese disaster management groups. So what does not seem like an obvious partnership, when things like this happen, then you have to make it obvious.
Yeah.
Sorry, I just wanted to add. Now, I know I said I'm not representing IIT Madras 100 times, but IIT Madras is doing two efforts. One is for water conservation, and one is for flood management. And these are being incubated, and they're working with local government as well as the central government to sort of see how they can make it scaled up on a bigger basis and actually effective.
I just want to take slightly different approach here, is that what happens is many of us are called after the disaster takes place. We know there are going to be floods every year. We know something is coming up, and what happens, we just pretend to be shocked and then get worried and then make things worse for everybody. I'm saying as a system, I'm not just talking about nobody. I don't think any one entity is to blame. I think what happens is, okay, so something like this is going to happen. So how do we, in anticipation, Dr. Sanjeev Jain, who's not here today, has spoken about a very interesting case where this woman develops dissociative symptoms a particular part of the year, and it actually took many psychiatrists to realize that it happens a few weeks before the floods are going to start. This is a woman in Assam. We know these have severe mental health ramifications. COVID had severe mental health ramifications for all of us, but for people with OCD, it was disastrous, right? So how can we create some anticipatory plans and not just do everything post hoc is something that I would really, worry for us or think for us. Yeah.
Professionals. They also, since I work in disability space, I've also realized that none of the NGOs or rehabilitation centers run by government or private entities speak about basic needs like clothing, for example. So how do we make that come in common dialogue, public discourse, so that those things are also made available? So that is invisibilizing clothing and mental health, further invisible need of people.
Yeah, I think when it probably just answering for everybody here would be a multi-sectoral approach, that we're not like healthcare professionals shouldn't be called after, they called before. What Smriti spoke about, what Rohan spoke about, I think it has to be a transdisciplinary multi-sectoral approach. I think that would be the best way to go about it.
And as a society, we also need to be sensitive about those needs, no? Otherwise, we also forget.
So one of the things that gets talked about a lot in terms of dignity is autonomy. But autonomy, again, is a very individualistic thing in the West. In settings like ours, we are collective autonomies. We make decisions together. So again, bringing back the community angle to it, what you said, okay, clothing, basic needs, food, water, shelter, that's exactly some of the stuff that, we feel is really important. You cannot treat someone's symptomatic pain if that person is living in a house where the roof is leaking and they're sleeping in the kitchen with the chula, the smoke in their face. So my job as a professional there is to go and assess their housing. I'll just give one example. I know we're running out of time. There was this 19-year-old boy who met with a road accident, and his mother was told, he was in the hospital for 3 months, and then his mother was told, just bring him for physiotherapy once a week, he'll be fine. So she's a single parent. She works in a plantation in Kerala. Their house is on a little hill. There are steps in that house. The boy can't walk, and he's got head injuries. He's quite big built. She's at work, fending for the family. If she had to get to a hospital for physiotherapy, it meant so this house is on a hill. They come down another hill, go up another one, and then they have to walk maybe 300 meters to the nearest road where there is no bus stop. 4 men from the village have to take the day off to carry him on a khatia, come there. She has to take an auto for the day to bring her back as well, which is a week's wages. Do you think he got physiotherapy? No. Till the home care teams found him. Now he can walk. But it means that we have to go there. So on a positive note, I just want to say that we are taking cognizance of what you just said. It is happening. I can speak for the palliative care field, which is why I say it's a social intervention because of this. So it is there. There are models of care there. And I think, we can all learn from each other.
My father has bipolar disorder. My daughter has depression. And so I have lived with as a caregiver for people with a mental issue, whichever way you want to put it. My father was a very brilliant man and, of course, faced a lot of problems throughout his career because of this. And my daughter, similarly so, I find that, again, we've talked about this, you have to peg yourself to the standards that society wants from you or supposedly expects from you. And structurally, I don't know, like now at an age when she's 26, when she's employable, there are 2 issues which I want to bring up. One is that post-COVID, so when my father when he had those sort of issues, there was no language. It was completely invisible. All of us had to deal with it. And in a very perverse way, I would say, neither did society, we didn't have the language to express it to society, nor coming from a very well-educated family, there was almost this desire that, you don't want to talk about, you don't want people to talk about it, the family doesn't want to expose it because it's almost as though it's a stigma on the family, as though they were responsible for this problem. And now I find that it's a very strange situation post-COVID. A lot of this language has come into society, mental health and stress, and a lot of maybe companies, larger companies at least, are structurally bringing in some kind of a change to make space for people who are feeling this. But for then I see that there is almost a denigration, and there's almost this societal, like, they just blowing this up unnecessarily, number one. But also then people like who are clinically depressed, like my daughter. I don't know whether there is a structural framework which is put in place for people like her who I feel, they have a lot to contribute and are quite intelligent, but require a certain framework where they can function properly. That's my question. And I want to know whether it's happening and whether you're aware of that. The statement that I want to make is, I think the one thing that I see is that in popular culture, whether it's fiction or creative non-fiction, there isn't enough talk about mental health issues, and maybe that is something which will help to bring a larger discourse in society, so it doesn't, it becomes very normalized.
Thank you. I don't know if we quite got your question on structural frameworks. Did you?
I got a bit of it. So stigma is something that you mentioned, and I was going to say that is probably the biggest challenge that we face, not just in this country, all over the world. Even in the West, where therapy is normalized, it tends to be medicines and pills as opposed to genuine therapy. My grandmother was bipolar. In those days, it was, like you said, there was no language, there was no vocabulary to discuss it. She went through all sorts of problems and treatments that were probably not effective in any which way form. I'm somebody who suffers from depression. I take very mild medication for it, but I still need it. The question that when it comes to the workplace, whether to disclose your condition or not is an ongoing debate. It really depends on the individual. It depends on the condition. It depends on how much accommodation that you need, reasonable accommodation that you need. I told my boss that I have ADHD, which means give me some space and some time to do what I need to do. I haven't told her about a bunch of other things. And it depends on the person and the condition, like I said. I think you also wanted to add something.
No, I think you've covered, and in the interest of time, I will not respond. If anybody else or the speakers want to respond? Yeah? Okay. So, thanks. Bang on time. Just wanted to conclude by saying that, we, on two things. One is that at the Banyan Academy, where I work also, we have colleagues from there. We're working on a sign language dictionary on mental health for the deaf community. If you actually see, there's no language. First of all, when she said language, I thought I'd say it, that there's no language for depression, anxiety, trauma, hallucination. It's only either you're happy or you're sad. You're worried. That's it. That's the tension, is what, that's the maximum extent of what Indian Sign Language has to say. So from that standpoint, the deaf community also experience a high number of suicides in the country, sadly. So when we say language, some of this is also happening. And I'm sure there are many other organizations here who are doing similar services. And when we say reasonable accommodation, also to people who don't know how to express the needs that they have. So that's probably something I'd conclude with. And just to say that, when we say stigma, we're always talking at high level, but, really about, would you date somebody with a mental health issue? Would you give them gossip? Would you trust somebody with a mental health issue with your office gossip? Will you invite them to parties? Right? I'm saying mental illness, it's my field, but with everybody else who's here. Somebody who has a verbal tic, would you invite them to a wedding or a solemn occasion or to a family prayer or a bhajan or whatever your faith may be? So I think these are the everyday invisibilizations that take place, and that takes immense patience, like Vidya said. And then we move on to meso and macro and systemic and policy level. But I think we need to start at home and with our own friends, and some of the naughty and evil things that we do that is for our pleasure, are people with disabilities a part of it? I think I'd just like to leave you with that thought. And thanks very much to all the speakers who came. We had a wonderful session, and looking forward to attending everybody else's. Thank you. Thank you for giving us this opportunity.